everyone. Welcome to the episode, and also welcome Dr. Jennifer Gaudiani joining us again. Thank you so much.
So happy to be back with you. Thank you for inviting me.
Oh no, honestly, we've recorded with you before, and it's one of our most listened to episodes, of course.
Amazing.
And even since that episode, we've had so many more medical questions from people, and we always think, oh, who do we go to? And then always your name, and everyone wants to hear from you. And you've just released a updated edition of your book, Sick Enough, so we can talk about that as well. But yeah, we're just excited to get to talk to you about medical topics, but I feel like you bring so much kind of humanity and clarity to those complex topics and kind of make it consumable for people. So yeah, we're excited to chat.
Oh, that's so nice. I can't wait. I'm ready to help if I can.
So, Dr. Gaudiani, so the first question we want to ask is a lot of people say, well, I can't be that bad because my bloods seem fine. I haven't maybe lost my periods, or there's nothing wrong with my ECG, or all of those sorts of things. How is it that somebody can have a full eating disorder and their bloods be fine, their tests be okay? What's going on there? Is the human body really resilient?
Yeah, you've got it. The way that each of our bodies responds to challenging or toxic or negative impulses is really determined by a lot of different things, including our genetics and our ability to listen to our bodies and respond to them. So there are some people who have eating disorder behaviors for 1 month and their body crumbles.
Mm.
Functionally, their gut shuts down and their hair starts falling out, and maybe even their blood work starts becoming abnormal. And there are other people who have been in an eating disorder for a decade, and not only are their, lab work results fine and their EKG all right, but even they really don't have that many symptoms. And both groups end up in a place where they end up saying, I'm not sick enough. Because the first group says, my body's betrayed me. I've seen people who are X, Y, or Z. They're thinner, they're this, they're that. They've been sick longer. So clearly I'm an embarrassment because my body has broken down so early. And the other group says, I'm not sick enough because apparently no matter what I do in my eating disorder, it doesn't matter and I'm quote unquote fine.
Mm.
And the upshot of the whole construct of sick enough and of the work that my partners and I do in our clinic is to say that just having an eating disorder, just engaging in whatever those behaviors are, much less the self-talk that goes along with them, makes you sick enough to receive care. There is no bright threshold where on this side of it, yeah, you don't need help, you're all right, keep going. Whereas on that side of it, you finally qualify. And it's important for people to hear me say that as an MD because I'm fully aware of the fact that they've heard the opposite from insurance companies when they were being authorized or not for a higher level of care, when they've gone to their GP who's super well-meaning, but who completely misses that there's a problem going on and says, "Oh, you look fine to me, don't worry about it." Um, or from family members or from colleagues, teammates, social media, sort of the entire world seems to be telling them, you're not actually sick enough, whatever shows up. And the fact that that's the inside voice
Mm.
innate to the eating disorder just feels so despairing and so gaslighting, and yet people know that's not right, but they feel reinforced and then they just dive deeper. So I really want people to hear from someone who's been in the field almost 2 decades. The truth is, the scientific medical truth is that if you have an eating disorder of any kind, regardless of the narrative or measurable things going on in your body, you are sick enough to get help and to turn it around.
Absolutely. Yeah, that's so powerful, isn't it? And I think you're right. Like, no matter what body people are in, they've been told that they're not ill enough. Like, I've literally heard it in every body type, in every behavior profile. So it's not really about the person or their eating disorder. It's about more awareness needed in the community, right?
Hmm.
Mm.
Also, some people can cling to one measure that's not showing us something. They might have lots of different things that show that things aren't okay, even invisible things, like socially in your head, things aren't okay, or you're cold, or what have you. But if there's something that they're like, but this has never got bad for me, or someone else is much worse on this. But is there like a reason why people have different profiles of symptoms and markers?
Yeah, I think it comes down to genetics. I'll often share the more common or familiar situation where, someone might have abused alcohol heavily for 3 years. That's it. And they present with severe liver failure.
Mm.
And someone else might be 90 and they drank pretty heavily their whole lives and they're sort of like, it must have been the whiskey, sort of like that's what kept me alive and kicking all this time. So the truth is that our bodies have different genetic susceptibilities to these different challenges that we face. And some just are super sensitive, and some seem to just be super resilient. And that is not a moral or ethical judgment. It's just biochemistry. It's an accident of biochemistry. Um, and either way, no matter whether you've got sensitive genes or resilient genes, keep recognizing that the very fact of an eating disorder isn't compatible with what matters to each individual unique person.
Mm.
And it is going to go badly. That said, I want to be really compassionate because I think it's very easy to immediately frame eating disorders as the bad guy or the abuser. And the truth is that that statement, while it clearly can become true, can make people feel shame that somehow they didn't resist it harder because almost always the ED starts out as trying to solve a really serious problem that the person feels they've got in their life. And I'm not talking about body image problems, I'm talking about a trauma history or a home situation that feels untenable, a social situation that feels really toxic. And the eating disorder initially offers itself as a solution, or people might be trying to cool off and calm neurodiversity, ADHD, OCD. So I want to be really, really respectful of the fact that EDs start out seeming to offer a helping hand. The problem is it never remains a helping hand. It always becomes something that's negative for your body, negative for your soul, negative for your heart, for your relationships, for your connection with self and what matters to you. So, I think it's easy to want to make eating disorders just one simple thing. It's just a brain disorder. It's just this. And the truth is, they're really complicated. And we honor the patient and their loved ones most by allowing ourselves to lean into the complexity and be like, tell me what it is for you. I'm not going to assume. I want to hear all the things this is for you because if I know that and I know what it started trying to solve for you and what it's continuing to try to solve for you, then as we work together, I mostly on the medical complications, but also on a big strategic front, we can help figure out what could take the place of that solution so that it's not this thing that's going to be so bad for you.
Mm.
Love that.
Love it. So powerful.
With the resilient genetics as well, I guess if you have resilient genetics in whatever form and whatever part of the profile of an eating disorder, that's not a reason to keep going with it, right? Like, my
Exactly
genetics are
right.
built for this.
Yeah, that's a beautiful emphasis. The truth is that patients will easily, as you said, find something that's going okay as a reason why they're fine.
Mm.
Even when all the measurables look crummy, if they're doing well in work or school, they're like, well, I must be fine.
Mm.
Um, And I love sharing. I don't think we shared it the last time, the house on fire metaphor that I use with patients, which is, I was an English major, and I like to speak in metaphor when sometimes the direct thing is going to bounce off, but the metaphor kind of sinks in a little deeper. And when patients are like, but Dr. G, my potassium's fine, or my weight's not as low as it used to be, or my weight is higher than it used to be, or whatever it is, dot, 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 they say, therefore I'm fine. I say, let me tell you the story of the house on fire, which is, and in this case, I'll just happen to use a female protagonist. There's a young woman standing outside of her burning house, and the fire department comes roaring up and says, we're here to put out your fire. And she goes, oh, I don't have a fire because the sidewalk's not bubbling.
Mm.
And the fire department is like, lady, you have a fire. I see the flames, I smell the smoke, I feel the heat. And they understand that she is having a moment where she's having a hard time understanding what's going on, and they go put out her fire. And so when my patients are like, but Dr. G, my EKG was all right today, I'll be like, oh, house on fire.
Mm.
Just because your sidewalk's not bubbling does not
Mm.
mean you don't have a house fire. And so, sometimes when patients continue to struggle with that and they push back because the ED is really powerful and it wants to protect itself, it wants to stay in place. They might be like, okay, Dr. G, but I'm going to push you on this. And I'm like, oh, push me because this is the right place to do it. Let's like really get into it together. They might even say, compared with my worst day,
Mm.
I'm better than I was. My behaviors are better. My numbers are better. So I'm probably fine, right? And what I like to say is, we're not going to compare yourself to your sickest day.
Mm.
We're actually going to come back to what you told me are your unique goals and values, because that's how we start all of our initial consultations with patients is, would you please share with me what your goals and values are? That helps to decrease the risk that with the power dynamic that exists, and even when I'm trying to be mindful about it, that I can impose my own belief set onto a patient. And that really undermines the validity of the relationship. So I'll go back to saying, hey, you told me that your values were connection, honesty, and service. And you also told me that your goals were to be able to graduate from your graduate school program, or that your goals were to be able to enjoy your grandchildren, or whatever they might have been. And I'll say, given the life that you imagined with me, and I sort of put one hand up a little bit higher in the air, that's what you told me you want. Here you are down at this place, and I put my other hand lower. What's the gap between those two things? Because if you were truly nourishing yourself consistently, resting, listening to your internal voice, able to meet your needs, able to be in relationship with the people who matter to you, and you had the energy and the cognitive strength and the lack of distraction to be doing all of these things you want, my two hands would be really close to each other. There'd be very little gap, and probably you'd be in a reasonable recovery place.
Mm.
But instead, let's look at those gaps. You told me you're exhausted. You told me your heart races every time you stand up. You told me your constipation is really a problem. You told me the bloating is distracting. You told me you're thinking about eating disorder things all day long, and there's not that much space in your brain. I don't care where you were in the past. The fact that there's a gap between where you sit now and where you wish you could be and think you could be, that's the gap that recovery needs to fill. That's what defines sick enough.
Wow. That's just so powerful. Somebody needs to keep listening to that on repeat when they start to gaslight themselves, because it's so common. So common to gaslight themselves, tell them they're not unwell enough. And yeah, no, thank you so much for that, Dr. G. Um, why do people struggle to define themselves as sick enough? And they feel like this need to hit a rock bottom before they feel like they're allowed to get help. Why do you think that happens?
I think it's innate to the
Mm.
eating disorder, mental illness piece.
Mm.
Um, and I think that it may also emerge from systems, whether these are familial, cultural, social media. religious, athletic systems that may have a tendency to tell people about benchmarks. And
Mm.
benchmarks can even be um, a beloved parent saying, I'm not allowed to sit and put my feet up until everything on my checklist is done. Sort of, I'm not complete enough to go take care of myself. Or a coach who says you can't rest until you've done these things because rest is only a privilege of having completed all of the things on this list. There's a lot in society. It's got a little bit of an ableist root to it. It's got roots in all sorts of different things, but the healthier and more balanced perspective is recognizing in any given moment that you can take a moment for yourself and take care of yourself. And I respect that there's plenty of elements of privilege that go into being able to make that assessment about yourself and to have the freedom to be able to say, I need to rest for 10 minutes, for instance, when you're in the middle of a workday. Some may not have access to that. But there are a lot of different ways that we can take care of ourselves during a given day that don't require everything to be done. So when someone is raised in that culture, and I would argue that there's a lot of that in all cultures around the world, that also feeds into this sense of like, no, I've learned my whole life that I'm not allowed to view myself as worthy of rest, recharge, comfort, expressing my full emotional range unless certain criteria are met. And I think when that setup combines with the start of sort of eating disorder or psychopathology, then that sense of not sick enough really gets reinforced. And I, from my perspective, again, as a physician who's done this for almost 20 years, I can assure every listener that there is no place at which the ED is satisfied.
Hmm.
And that I have patients, I had patients back in the days when I was helping run a hospital program, who were so critically ill across every measurable and still confessed to me with tears in their eyes when I would come in for my first meeting with them, I'm so embarrassed to be here because I'm not sick enough. And there are some patients who will say, Dr. G, I hear what you're saying. I hear that this is a problem, but I'm just sort of waiting for a sentinel event to really actually tell me that there's a problem.
Hmm.
And there's been plenty of times that I've looked them in their eyes, so many patients, and said, the only next thing that could happen is one that will leave you permanently neurologically disabled or dead.
Hmm.
You have all of the sentinel events. You have all of the findings. And so this is true at every stage of an eating disorder, at every level of medical formal acuity. There's a sense that I'm never enough. I'm never sick enough. And so recognizing that there is no place where the ED will be like, all right, you got there. You can
Hmm.
now start to seek some comfort. Then we have to address this from the very beginning and just really highlight every single body manifestation to show people the physical side when we have access to it. And again, when there aren't certain physical findings, we just say like, okay, well, there's those resilient genes, but let's go back to those goals and values. So there's always something one can say if you're really focused on it to help people understand they are worthy of turning this around now.
Mm.
Mm.
It's like that bigger picture of health and life kind of thing. And things could be off in one area, you could be fine in another. But if there are enough things that are off that you're not enjoying the quality of your life, you're not living in line with your values, you're not meeting your goals, you're not pleased with how you're spending your time when a year passes, then that's kind of enough.
That's right.
Mm. And I think it does link to this disconnection from self, like what you were saying, Dr. G, of this idea of like, I'm not worthy of rest, I'm not worthy of joy, I'm not worthy of this or that, I never deserve it. But realizing you're never going to be able to deserve it. There's never going to be enough of anything that you can do that you're going to say, right, yeah, I'm allowed to take a rest today. I don't have to be this productive or do that or So knowing that that kind of seeps into the eating disorder. And I think that's why when you heal from your eating disorder, you do a lot of healing in other areas of your life too. And you start to listen to your body and yourself and boundaries, all of that kind of stuff, relationships with people, it all changes. It's so much more than just body, food. It's kind of life changing because you connect back to who you are and what you really need.
It's so true. I've often said to my patients that when they express to me a fear that when they're no longer doing behaviors, and if they start from an underweight perspective and they're back to a normal weight, because of course eating disorders exist across body size, and it's the rarity that people are underweight in an eating disorder. But let's say that they say, once I'm weight restored and I'm not doing behaviors, how will anyone know I need
Mm,
support?
yeah.
I'm so worried that I'm not going to be healed when those parameters are met. And then my team will leave me, and I know I'm not going to get my needs met. So the ED, both the behaviors and maybe the physical outcomes from it, show people that I'm not all right and I still need help. That's really, really common. And it's actually not uncommon for loved ones and friends to accidentally trigger that by being like,
Mm,
wow, you're so hardworking while you're sick. Imagine what you'll be able to do when you're better. And it's just
mm,
like, ooh, because already the person is just feeling so overwhelmed and exhausted, and they don't need to hear that the expectations are going to rise when they're better from their ED.
yeah.
And so, what I'll say to them from the jump is, believe it or not, even though this whole process of learning how to nourish and not engage in behaviors and to tolerate and be compassionate with your body feels like the work, believe it or not, oftentimes the work actually starts when you have no more ED behaviors, when you
Mm,
are able to nourish yourself consistently and completely. And so it's the opposite of, yep, toodaloo, we'll see you later once you're at the bare minimum. Actually, that's when the work becomes really interesting. And that's when, relational connection with your team may deepen because you're not stuck in this sort of basic ping pong game of like, please eat, I can't eat. Please don't purge, I can't not purge. You
mm,
get into the really yummy, fun, rich, whole human work only once the ED behaviors are gone.
Mm.
great.
So
Yeah.
true, because it's life beyond as well, isn't it? Like you need the behaviors taken care of and out the way to create space for, and what next? What are you interested in? What are your values? Let's explore. It's trial and error. It's that horrible exposing feeling of like, oh, what do I do when my eating disorder's gone? But that's so much a part of recovery as well. Like it's not just get rid of the eating disorder and then you're left with nothing. It's like, and what do you turn to now? What are you interested in? What do you like doing? How do you spend your time?
Yeah. Yeah. And I've been through that process with so many of my patients. It was the core reason why I founded the clinic, is because I wanted to have those long-term relationships with people and to see them walk that pathway and then get to that place where, yes, we're still talking about optimizing their digestive health, for instance, when we have sessions, but we're also talking about, oh, I'm going to be going on a date this Saturday. I'm kind of curious about like, what I want from this relationship potentially, not just what am I going to order in the restaurant, but like, how do I want to show up as my whole authentic self? And like, that is so much fun. The
Music.
fun part of recovery really takes off
Mhm.
after those initial, incredibly hard for many people, sort of nutritional, body-oriented things are in a good place.
Hmm. We'll be back to the episode in about 30 seconds, but first we want to invite you to our Rewired in Action community. If this podcast helps, but you'd like more support, practical tools, and answers to your questions from us, we'd really love for you to join.
We created this community because we kept hearing from listeners that it's so hard to hold on to motivation. Even when you really want to recover and you're sick of living in Groundhog Day, it's so hard to make that change in the moment. We know exactly what that feels like, and that's why we made this community for you, the one we wish we had in our own recovery to help you break the eating disorder cycles that are keeping you stuck.
We meet twice a week on Sundays and Thursdays at 5 p.m. Dubai time, and all the sessions are recorded so you can catch up if you need to. That means that no matter what your time zone, you can still join, and in fact, lots of our participants rewatch the sessions a few times during their week.
It's anonymous and listen only. We know how important it is to have a safe space without comparison or triggering details. Our members span 5 decades of life at many different stages of recovery, so whatever your age or stage, we'd love to have you.
It's not a replacement for therapy or treatment,
but it is consistent, practical, compassionate support that really helps people make meaningful change in their recovery.
You'll find all the details in the show notes, and we would love to support you.
All right, now back to the episode.
I know one of the things people are really scared about in recovery is their metabolism and the kind of recovery of their metabolism. And it's one of the questions we've had is from, we run a community, and someone in the community has said to us that they've heard you say in another podcast that metabolism increases with more food. But for this person, they've had an experience of regaining weight on a lower intake and now feel scared about increasing their intakes. They're like, but I've managed to gain some weight on a lower intake, so I should just stick with this. But then they're also worried that, what if I don't heal my metabolism? What if my bones don't get better? What if my bloods don't improve? What my thoughts, my relationship to food, the rules, everything like that. So I think some part of them does know they need to have more, but they've got this fear of, oh, but if I was able to gain weight on a lower amount, and actually it was reinforced by a dietitian as well.
I bet. Yeah, I bet it was. Yeah, that's such a good question. And I talk about this a lot with my patients. So let's go back into some essential science, and then let's talk about how this shows up across the spectrum of actual human experience. Western medicine falsely teaches us. I was taught wrong. Many, many people are taught wrong, that the metabolism is a fixed point. Everyone burns exactly this many calories a day, plus minus the amount you work out. And therefore, we're still in the false narrative here. If you eat above that, you'll always gain. And if you eat below that, you'll always lose. And if somehow that's not happening, either you're not telling the truth about your eating behaviors, or something weird is wrong with you, and the doctor sort of throws up their hands and is like, I don't know. This is incorrect. This is scientifically wrong and has been proven beyond a shadow of a doubt by so many different studies, not to mention, the fact that I've gotten to bear witness to this for 2 decades. The truth is that metabolism is highly dynamic. And that means that if you undernourish by some, your metabolism will fall to approximate that intake. And if you then decrease your intake more, your metabolism will slow more. How does it do that? By making you chilly, by slowing your digestion, by slowing your heart rate, by making you feel less energetic and more fatigued. All of the different physical signs that we see, whether it's in starvation medicine, and of course, starvation is totally neutral of body size and shape, or whether we see it in relative energy deficiency of sport, that's been very well documented by the International Olympic Committee as far as what athletes experience when they're undernourishing relative to what they're asking their bodies to do. Identical. The body doesn't know the reason for inadequate nutrition. It just responds physiologically. So then people find themselves in a place where they're like, gosh, I'm really not eating that much, and my dietitian thinks I need to eat more, but my weight isn't changing. So that means 100% guaranteed for sure, if I eat more, I will clearly immediately begin gaining weight. Mm. And we're going to talk about the human experience and the bell curve of human experience in a moment. But broadly speaking, in fact, when the person starts to eat more, their metabolism warms up to that level. And then they start to eat more and their metabolism speeds up further. Their hands get warm again. Their bellies empty more normally, etc. And of course, at the extremes, yes, probably someone will gain weight at the extreme of very, 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 very much overnourishing compared with what their body needs on a daily basis. And if they very, 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 very much restrict below what their body needs, they may lose weight, at least initially. Usually the body really tries to protect against that, but it can happen, of course. So that is scientific truth. And anyone who's been through renourishment before, even if they have a thought of like, well, I know it happened 2 years ago in treatment, but maybe things are different now. That's a very, very common, sort of obsession and fear. But the truth is that, again, 2 decades in this shows that this is the science, and
Mm,
that yes, each, renourishment period, regardless of body size, may be different a little bit. This is the science.
mm,
Now, let's say that somebody um, has the experience that your patient had, and they find that, like, oh my gosh, my weight is actually going up at a relatively lower caloric rate. This comes back to the fundamental biology that we all have installed in us, whose prime directive is avoid death by starvation. The only reason that the three of us and the current listeners exist on this planet is that millennia ago, our most successful relatives had the genetic tweaks, the metabolic tweaks to survive starvation.
mm,
So, there are two ways to understand when someone does begin actually restoring weight at a lower than expected caloric rate. Three ways. One, people should just stay off the scale as they start to renourish, because they're going to rehydrate in certain ways as they renourish. They're going to have digesting food throughout their probably relatively slow digestive tracts that can build up and cause quote unquote weight on the scale. And so they can say, oh my gosh, what is this? I've gained 4 pounds in my first 2 weeks of like just barely eating. That's not weight. I mean, like, yes, it shows on the scale, but that's hydration. That's digesting food. That's not muscle and fat and actual body weight. But the ED is going to have a really hard time assessing that. So they can sort of see that, decide that they're broken, freak out, and go back to restricting. And that's not right. Okay, so that's one thing. That may just be like a misinterpretation of the data. Two, there is a bell curve of human experience, just like we talked about genetically at the beginning. So it's possible that somebody has really beautiful protective genetics that are tuned in to somehow find a way to restore some real weight at a lower caloric intake than you'd expect. I mean, brava body, right? Like that is so protective and lovely and miraculous, even if it makes the person freak out. But, we have to hold space for that and be like, look, let's watch it over the next 4 to 6 weeks. And let's also recognize that even if you seem to be actually gaining weight, beyond what I talked about before, the sort of hydration and digesting material, even if you seem to be gaining weight on a lower caloric level, let's just continue. Let's persist. Let's really focus on helping your body enjoy enough consistent food that's really satisfying throughout the day, etc. Let's give your body some time because it's been through a lot. So let's not like immediately rush to judge what's happening. The third one is that some patients really struggle to push up on calories properly. If you really want to make your metabolism go, you got to really eat. And so some of my patients who get stuck at a lower caloric level despite their dietitian's encouragement, their body, their metabolism has come up to that level, but then their body is like, well, I'm going to do what I can with this
mm,
amount of nutrition because I want to save you.
mm,
So the truth is, if people want a faster metabolism, they have to eat more.
mhm,
The likelihood is that everyone will go through this hypermetabolic state if they trust that they can really nourish at a good level.
Yeah, trust the
And as
process.
far as bone recovery, et cetera, again, that's always going to be a bit of genetics as well, because I've got patients who go into the not sick enough realm when they're like, I still have my period, or, I'm still making enough testosterone and my bones are fine. I guess I'm fine. And then I say, sidewalk bubbling, house on fire,
Mm,
But most people will be able to at least stem bone density loss with recovery efforts. And some may be able to restore some bone density. A fewer proportion can actually fully heal their bones with modern medications, etc. And that's really awesome. But bodies want to heal. They want to heal. So our job as treatment teams, patients' jobs is to give the body the opportunity to do what it knows how to do. It is biologically programmed to heal when it is exposed to the right set of circumstances.
I love that so much. I think it's such a reframe from when you've got an eating disorder, you feel like it's you against your body. You're like, why is my body not doing this? Why is it this shape? Why isn't it playing ball? Why is it not catching up? And like what you're saying is that actually your body's on your side. It's trying to keep you alive. It's trying to heal. It's trying to just allow you to keep having this human experience. So yeah, I really love that. And Dr. Gaudiani, something we really want to talk to you about is your new edition of your book. We're really excited to see that because we love the first edition. So I know that you brought in some new chapters around neurodivergence and eating disorders in athletes, but maybe you could just start by telling us like why did you make this updated edition?
Yeah, I feel so proud of it.
Oh,
So I realized it had been about 7 years of clinical practice since I had written the first one, regardless of sort of when it actually came out. And I've just learned
mm,
so much in these 7 years, usually from my patients, their loved ones, their clinicians, but just in the course of doing the reps, I've learned so much. And because I know that I'm, only going to get to see a tiny fraction, or my clinic is only going to get to see a tiny fraction of the patients in the world who could benefit from our knowledge base. Since one of the pillars of establishing the clinic was to improve the quality of medical care for people with eating disorders around the world,
mm,
it felt really important to write a second edition to fix the errors in the first one because there were still mistakes, as I learned, to reorganize it, to bring more of the heart and soul that I've come to understand, as well as more of the nitty-gritty medical,
mm,
sort of management strategies. Um, and to try to get it in as many hands as possible. And that's patients, their loved ones, and clinicians, so that people could better understand themselves, better understand their loved one, or better serve someone who comes to them. Oftentimes when someone says, gosh, for one reason or another, I won't be able to get to your clinic. I live internationally, or I can't access the clinic. What should I do? My recommendation is as much as you can, find a super nice GP, oftentimes a nurse practitioner or physician assistant. MDs are great too, but sometimes we're a little bit less receptive to new things.
mm,
Um, and bring the book and say, hey, you don't have to be an expert in this. I get you don't have expertise, but I don't have access to anyone else. Could we collaborate? Could you look at chapter 17 together? And I think it's relevant to me. And could we work through some of these things? Because
mm,
I want to try to get better, even though I'm scared. And I think this would help reduce barriers. So, that's the reason that I updated it. And
mm,
then there's just a few populations and a few things that I've learned helps to be said that I wanted to include in it. So there's a chapter on sort of just the themes of recovery. There's a chapter on neurodiversity, on other influential psychiatric diagnoses, on complex digestive problems, lots more information on binge eating disorder, a whole starting chapter on weight stigma that is the umbrella that covers everyone with an eating disorder, regardless of body size. I did a fully updated, lit search across every single chapter and really buffed up those on atypical anorexia and ARFID and mast cell activation syndrome and POTS. And I just wanted to give sort of as to the extent that I could find it or the extent that I practice it,
mm.
really the best of medical care for eating disorders in a way that I hope is very accessible to people. Plus, just a couple weeks ago, the audiobook was released and I got to record it this time.
Wow.
So it's me and it's
Ah,
people, who want to sort of have that cozy experience of hearing me say the things the way that I like to say them just feels like a fun, special little piece.
oh, that's amazing. Gosh, that must
Definitely.
have been a lot of work.
It was super fun. I love reading aloud. I read aloud to my kids just years and years, as long as they'd let me. And so it was really a fun experience.
Amazing.
Oh,
Amazing.
incredible.
I mean, we'd love to hear more about the new chapters, the bits you've elaborated on. You touched then on neurodiversity. So, from a medical perspective, from your perspective from the book, how do you see that intersecting with eating disorders in presentation, also an approach to recovery, risk? Like, how do you
Yeah,
differently go about treatment?
yeah, that's a lovely, thoughtful question. Um, Part of sharing a bunch of new knowledge base involves the humbleness of being like, I didn't know this 7 years ago when I, was regarded as an expert in the field. And you have to just, I'm going to be 50 this year, and nothing could make me more joyous, even though I don't want to cause harm in any way, than to be able to be like, oh, I was wrong, or oh, I didn't know something. Thank you for letting me know. Okay, great. I'm going to incorporate this. Let's do better this time. So I feel like I'm at such a joyful stage of my career where I'm really ready to be like, oh, shoot, I didn't know that. I'm so sorry. Yes, let me do better. So one of those things is in neurodiversity. I was in the field a long time before I really started to understand that. And I know I'll continue to learn. But what I've come to really appreciate, and there are a bunch of helpful stats that are all fully cited in the chapter, is how common concurrent autism and eating disorders are. For instance, just to take an example. And when I have patients who are neurodiverse along autism lines, I just have come to have such a sense of joy in caring for them and a respect for how poorly the system really supports them at present. And that's across all levels of care. These are folks whose autonomic nervous systems need often to be in motion to be soothed. So that's rocking, bouncing, um,
Mm.
swinging, just really helps their beautiful nervous systems cool. And yet, these are the very patients who, as they walk about in treatment or jiggle a knee, are told, you're trying to burn calories,
Mm.
when that's just not what's
Mm.
happening. And that's part of the sort of the medical trauma of eating disorder treatment, when someone is told what's going on and they know that's not the case,
Mm.
but they're powerless to be able to respond back to it. And so increasingly, when I, for instance, need to send one of my patients who's neurodiverse to a higher level of care, I'll do a lot of advocacy to say, please provide this patient with a ring stabilized exercise ball to bounce on during session. And, if people are like, that's not fair, they're getting to move during session. Bouncing on a ring stabilized exercise ball is not burning calories, people. If everyone wants an exercise ball, maybe they should be allowed to have an exercise ball. But, this is part of accommodations. This is reasonable medical accommodations for what someone needs to actually thrive during treatment. During a session, I might, once I get to know my patient's needs, and I don't assume them, I ask, what would make you more comfortable in session? They might need a weighted lap pad. They might want to have the clinic lights off. Um, they might need to play with a fiddle toy. They might need to just be jiggly in their body while we have a session, for instance. And I just warmly welcome that. Then you've got the sensory aspects. So many folks who are neurodiverse have a different relationship to the sensory taste, touch, smell, texture of food. And again, in treatment programs, they're often told, that's your eating disorder talking. It's so funny how I use a male voice when I say that. Um, but it's not. And the idea that for them to be able to get privileges at PHP to, go do yoga on a beach or something, that's predicated on them being able to eat certain quote unquote challenge foods,
Mm.
ignores the fact that that may not be a challenge that's relevant to them.
Mm.
Somebody who's autistic may be like, I'd actually be perfectly fine eating the same meals 3 times a day that are calorically adequate, plus snacks. I don't really need to be able to eat a steak sandwich to live a good life. That's not part of my value system. And I don't think that my neurodiversity is ever going to allow that. We have to honor that. So many of these folks are called problem patients in treatment settings, when in fact, they're just different. and magnificent. And if we can show up and really find the joy in their difference and change our treatment to meet their needs rather than ask them to change the way they are fundamentally structured to meet our needs as treaters, then we put it in a patient-centered perspective, which is just so much likelier to result in recovery.
Mm.
That's so powerful. I completely agree. And it makes people feel so seen from what you've said.
Mm.
And the other area, Dr. Gaudiani, that you've also included in this new edition is about athletes. And I think maybe this has always been a problem amongst athletes, but I feel like now awareness is growing. So, how does somebody kind of understand that they do have an issue when so much of being disciplined and training and being regimented and rigid is part of being an athlete? How do you know when it is a problem? And could you also talk about like the relative energy deficiency as well?
Yeah, absolutely. So REDS, or relative energy deficiency of sport, is the new term that the International Olympic Committee has used in lieu of the old female athlete triad, which was way too limited on zillion fronts, from gender perspective to, all of the actual ways that a body suffers when it's undernourished. And so essentially, we now have a lot more studies compared with 7 years ago, and many of them are cited in the chapter on on just how common it is for an athlete without an eating disorder to accidentally undernourish in ways that affects their physical health, their
Mm.
mental health, and their
Mm.
performance. So, I've had such fortune now to care for athletes from, the person who just wants to enjoy yoga in their own life, all the way up through elite athletes, that I've just learned so much. And the dietitians and therapists that I've worked with who really specialize in eating disorders and in athletes have taught me a ton, as have the individuals themselves. Um, when you look at the book and you look at the different the sort of the criteria for REDS, it just means low energy availability, meaning I'm not nourishing enough compared with what my body needs. And all of the same signs are there. The my hands are cold, my digestion is slowed, maybe my sex hormones are off, and maybe there's more injuries going on. Maybe my brain just isn't in the game as much because it's distracted thinking about, what did I eat? What will I eat? It's not that those people have eating disorders, because of course athletes can just have eating disorders, but RED specifically speaks to the athletes who are just like doing what they think is right or what their coach has asked them to do and have undernourished.
Mm.
And this again can happen across all body sizes. There is not any kind of a BMI cutoff for REDS. And it happens in all ages. I'm seeing a lot of boys
Mm.
get REDS because there's all these orthorexic thoughts about sugar or about body type. And, their well-meaning coaches are like, hey, let's really eat healthy this season.
Mm.
And, suddenly you've got someone who's got no energy, or they've got a stress injury, or their brain starts to get a little obsessive and a little over-focused on calories, because when our brains are undernourished,
Mm.
they function differently cognitively. And so the idea is that the message we need to be giving to athletes is, let's pay attention to how your body is operating. Let's pay attention to how your performance is, how you're recovering from injuries. My elite athletes inevitably tell me that when they're nourishing consistently and adequately, they respond to their training so much better. They're not sore the next day. They don't get injured. And if they do have a fall with an injury, they recover so fast.
Mm.
Whereas when they're not nourishing enough, even if they're in exactly the same body size, all of the opposite things are true.
Yeah.
So, when athletes think about getting an edge in our orthorexic diet culture and thin focused society, they often think, oh, I should be cutting back on things. But I've learned from great teachers like Beth Hartman McGilly that you can sort of tell whether someone is operating from an athletic identity primarily or verging towards disordered eating, eating disorder identity primarily, based on their motivations and their actions. So if someone is truly acting from their athlete identity, and you say, gosh, from what you've told me, and this is often a dietitian doing this work, you actually need to increase by 700 calories a day and take one more day of rest a week. And that's really going to allow your body to optimize your work and your performance. Someone operating from athletic identity will be like, okay, I will do it. Because what I want is to show up on the stage, on the field, on the track as the strongest and most capable athlete I can be. Someone who has crossed the line into disordered eating or eating disorder is going to operate from a place of fear. And they're not going to be able to do that, even though that's what's needed to do their sport. So they might say, no, 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 I can't do that because of my sport. But if you're like, no, dude, what I'm telling you is this is how to optimize your sport. So if you're not doing it, I think this has crossed a line and we're going to need a different kind of therapeutic approach.
I love that differentiation.
Okay.
Like a fragile line for some people, I imagine, as well. And even like what
That's right.
starts out as, because I've had people say as well, like, oh, I was doing it for speed or like to improve my performance, but it's not a sustainable, like it's then ended up not doing that. Even if it did have a positive impact at one point, like, is it a sustainable strategy? Not to mention every other area of your life that's now impacted and controlled and all the eating disorder fallout that comes with it.
That's exactly right. It can be quite confusing at first because people may find that their performance does transiently improve. That strength to weight ratio is very real in many sports. And so it can feel confusing because they're like, wait, I know I'm not really nourishing quite well enough, but wow, I'm having some really good outcomes. That is going to last for some short period of time.
Mm.
And in the meantime, you're playing a game of roulette because while you're hoping that you're going to maybe make it through the next month and this particular competition or this whatever it is, the risk rises each day that you're going to end up with a stress injury,
Hmm.
that you're going to end up psychologically in a place where in the moment you don't have the nimbleness to make the good strategic decision, or where you're going to have something that really keeps you out of your sport for a long time. So it's tempting and it's confusing, but in the final analysis, someone truly coming from athlete identity, and this isn't just a someone who is an athlete, this is their coach, this is their family. They've got to keep the big picture in mind. In climbing, for instance, I think it is vitally important that everybody in the climbing sport say, we will not tolerate a culture in which athletes are harming themselves and putting their bodies at risk for a short-term gain. We don't allow that with steroid use. There is a bright line with steroid use. This is harmful for the body, even if it causes a temporary benefit. It's not allowed, it's banned. It's much harder to ban Red Z physiology that is essentially doing the same thing, giving a brief benefit, maybe, with a clear downside and harm.
Mm.
But it is the responsibility of coaches, of families, of athletes, and then really the athletes are the protected sort of population here. They should be protected by the structures of the sport around them to say, we won't accept this.
Mm. Wow.
Wow.
Because also that's in a world of athletics as well, as in everyone's kind of focused on performance and that kind of thing. But that person is still also an individual in their own life. So they also carry other identities, family, like your values, connections, social engagement. So even if you're focused on performance or whatever it is in your sport, there's other identities to consider, I guess, as well.
Yeah, there absolutely are. And many athletes who are on this borderline don't want to be driving their body to that level. They know it's not good for them. They're not happy. And
Mm.
yet there's not that sense of sort of general protection of someone being like, hey, I see you. What's going on?
I bet
No,
it's
we don't do that
confusing.
here. And so given what's at stake, whether it's a college scholarship or whether it's one's livelihood, there is a responsibility to step in and be like, we will not, as a system,
Mm.
allow and promote behaviors that are fundamentally harmful. We won't do it, and we're going to have a culture shift. That's what I want to have happen across the board. Yes, I am idealistic, and yes, there are ways in which this is already improving.
Yes. So another question which has come up in our community is around digestion, digestive muscles, people ending up with really horrible GI conditions like gastroparesis, which you've alluded to earlier, sometimes can happen very quickly for a person, sometimes can happen after a very long period of time. But what determines somebody's digestive recovery and how do you help with these sorts of conditions?
Yeah, I would say that that is one of the core processes that the clinic helps with is complex digestive distress. From a high level, we know that any mammal exposed to a piece of negative conditioning, pain, nausea, bloating, they're going to become avoidant of
Mm.
whatever it was that caused them harm. And this is true in mice models, and this is true in human models. Um, so when somebody who's already very much in their head about recovery behaviors feels lousy physically in their tummy each time they eat, it's just going to make it that much harder for them to
Yeah.
nourish. I think historically, folks have gotten the message, well, that's part of your eating disorder. As soon as you're recovered, it's going to get better. And like, that's not wrong, but it misses the fact that someone may not be able to achieve that recovery because of the barrier of the digestive distress. And anything that involves slowed digestion, so that's gastroparesis, it's constipation, it's very hand in hand with small intestinal bacterial overgrowth or
Mm.
SIBO. It's pelvic floor dysfunction, it's abdominal wall dysfunction. All of those are medical manifestations of undernutrition, irrespective of body weight or shape. So we both have to name, oh yeah, the reason you're nauseated, after we've done a good history and maybe some evaluations, is because your stomach isn't emptying in a timely fashion to make room for more food, and that's called gastroparesis. And it's almost universal in those who are under eating, regardless of body size. And there's things we can do to help it feel better until it is healed with nutritional rehabilitation. And among those there are some dietary choices we can make. Decreased fiber is really, really important for those with gastroparesis. That can be tricky because fiber is often, or high fiber foods are often safe foods for people.
Mm.
So what I'll sometimes say is, I want you to have as much autonomy in this process as possible. Where possible, I want you to make a choice for your body. So if somebody's like, Dr. G, I get so bloated right after eating and I feel nauseated and I feel full for hours, I can't increase my calories. What I often say to that is caloric increase has to be non-negotiable if that's what your dietitian says. So either you can stick with safe foods that you're eating in higher volumes that will make your tummy hurt more, but maybe will make your brain a little bit more comfortable. That's one option. The other option is to nourish with lower fiber, highly calorie dense foods with greater focus on liquids and semi-solids, which digest and pass through the stomach easier. And then your body will feel better, even if your brain is a little louder.
Mm.
But either way, the nutrition must be non-negotiable. And then beyond that, there are medications that I use. Those are described in the book that really can help bridge to actual healing. There's great physiotherapy or physical therapy that can be done that can make a massive difference in people's bloating and discomfort and constipation. There's so many things that can be offered that are well beyond just eat.
Mm.
Mm.
Amazing. I
Really
mean,
lovely.
a
Thank you so
complicated
much.
place to be as well, that battle between body and brain.
Yeah.
Really is.
Yeah,
Yeah.
really difficult place to navigate.
But nice to know there are options, there's ways through it, just to get the help and the support.
Yeah.
Get the book.
Oh, get the book, definitely. Dr. Gaudiani, honestly, thank you so, so much. You are amazing. I don't know how that session went so quickly, but honestly, it was so helpful. We learned so much, and everybody listening will have too. Thank you for everything you do in this space. We appreciate you so much.
Oh, I appreciate you too so much, and I appreciate your wonderful questions. It was so much fun to join you today.
I'm definitely listening to the audio.
Yeah.
I'm
People can
definitely
skip around. I mean, it's 19 hours of audiobook. So, people
How
can
did you
really
do
skip
that?
around and be like, I'm just going to listen to what I think I'm interested in or what's
No,
relevant
it's
to
all
me.
golden. It's all golden. Thank you so much.
Thank you.
I hope to have you on again.
Yeah.
Bye.